Good morning. Today we are going to discuss about lichen planus. It is a chronic autoimmune mucocutaneous condition which affects parts of cutaneous tissue and oral mucosa. According to WHO, it is characterized as a precancerous condition which affects 0.5 to 2.2% of the population. Having female to male ratio is 1.4:1. Age more than 40 or around middle age people, and one third of the patients are asymptomatic in nature. Coming to the etiology, it is considered to be an autoimmune disease where cell-mediated immunity is thought to play a role. Clinically, there are six variants of lichen planus are there: reticular type, papular, plaque-like, erosive, atrophic, and bullous. Generally, oral lichen planus are bilaterally symmetrical condition. Most commonly, they can be seen on the buccal mucosa, tongue, and gingival region. Involvement of other mucosal surfaces also has been noted. Buccal mucosa is seen to be involved in 80% of the cases, followed by tongue, which is 65%, lips 20%, and gingiva, floor of the mouth, and palate seem to be involved in 10% of the cases. Reticular pattern, it is the most common, asymptomatic, and having bilaterally symmetric presentation, which consists of elevated fine whitish line that produces lace-like pattern of fine radiating lines, which is called as Wickham striae. Papular pattern, they are whitish elevated lesions of 0.5 mm to 1 mm in size. Erosive pattern will be having central area of the lesion which is ulcerated, and keratotic striae can be seen peripheral to the site of erosion. According to the literature, it is reported that only atrophic and erosive form of lichen planus undergo malignant changes, and this could be because of the atrophic nature of the mucosa rather than the specific disease. Plaque type mainly seen on the dorsum of the tongue or buccal mucosa. Atrophic, it is similar to the erythematous background of the reticular form, and bullous pattern is very rare. According to WHO, there is modified diagnostic criteria for oral lichen planus. There should be presence of bilateral, mostly symmetrical lesions. There should be presence of lace-like network of slightly raised gray-white lines, which is reticular pattern. Erosive, atrophic, bullous, and plaque type lesions are only accepted as a subtype in the presence of reticular lesion elsewhere in the oral mucosa. Extraoral lesions in cases of lichen planus are seen to affect particularly in the skin and appendages. Cutaneous lesions are seen in the cases of 15 to 35%. They will appear as flat-topped violaceous papules, and these lesions can be seen mainly in the regions of genitals, wrist, and ankles. If the lesions are seen in the scalp region, they may cause scarring alopecia. This is the clinical picture showing skin lesions in cases of lichen planus. If this condition is affecting the nails, there will be pitting of the nails and nail beds, and there will be permanent nail loss. About half of the patients with skin lesions have oral lichen planus, and 25% of the cases have alone oral part of the lichen planus. Complications, the main complication of oral lichen planus is the reduced quality of life related to the soreness or pain, particularly in the ulcerative or erosive lesions. The second one could be the candidiasis, which also complicates oral lichen planus, especially when more potent topical steroids are used in the treatment. Under the differential diagnosis, cheek biting, lichenoid reactions, leukoplakia, and hyperplastic candidiasis and DLE can be considered. Diagnosis can be made by clinical examination or bilateral symmetric clinical presentation of the lesion by doing immunofluorescence testing or doing biopsy. Treatment, immunosuppressive agents like azathioprine and cyclosporin is considered to give good results in the cases of lichen planus. Steroids are considered to be a mainstay of treatment, where 0.1% of topical ointment triamcinolone acetonide is used. Systemic steroids can also be considered in the cases of aggressive lichen planus. Daily dose of 100 mg of dapsone is also considered to be a safe and effective in the cases of bullous and erosive form of lichen planus. Coming to the malignant transformation for oral lichen planus is considerably low. and it does not exceeds an incidence of 0.2% per year. Lastly, a syndrome associated with oral lichen planus is Greenspan syndrome, which is a triad of vascular hypertension, diabetes mellitus, and lichen planus of the oral mucosa. Thank you very much for watching the slide.